everyone, and welcome back to the Deep Dive. Today, we're diving into something absolutely crucial for nurses: medication administration. Think about it. Whether you're in a bustling hospital, a quiet clinic, or even helping out in a patient's home, nurses are truly at the heart of preparing, giving, and evaluating medications. It's a core responsibility in helping people get well and stay well.
And it's far more than just following instructions. Medication administration is really a dynamic blend of deep scientific knowledge and sharp clinical judgment.
Right.
As a nurse, you're pulling from so many areas, from legal guidelines and pharmacology to understanding how drugs move through the body, pharmacokinetics, and even the math behind safe dosing. It's a truly multidisciplinary skill.
Exactly. So our mission in this deep dive is to unpack this complex topic, drawing from fundamentals of nursing. We're going to focus on how nurses ensure medication care is safe, effective, and truly centered on the patient.
Yeah, that patient-centered piece is key.
Expect practical insights, common pitfalls to avoid, and a clear connection to real-world nursing competencies. Let's get started.
Okay.
Okay, so before a nurse even touches a syringe or a pill bottle, they're navigating this huge legal and ethical landscape. It's truly the bedrock of safe medication administration, wouldn't you say?
Oh, absolutely. Think of it as interlocking safety nets, sort of. At the federal level, the U.S. government, primarily through the FDA, makes sure that medications are safe and effective. They mandate, really rigorous testing before any drug reaches the market.
Okay.
And a key tool here for nurses, something you should definitely know about, is the MedWatch program.
MedWatch?
Yeah. This is where healthcare professionals can voluntarily report adverse medication events, those serious unexpected reactions. It's crucial for continually improving patient safety. It's how we learn.
So it's not just about approving new drugs, but constantly learning from what happens out there in practice.
Precisely. And then beneath federal laws, you have state and local regulations that often add more specific controls.
Right, like state nursing practice acts.
Exactly. The NPAs define your scope. And plus, every healthcare agency, like a hospital, has its own policies. These can often be even more restrictive than government laws, all to enhance safety.
Oh, okay.
For instance, a hospital might have a rule to automatically discontinue narcotics after, say, 3 days. That prompts a reevaluation, prevents unnecessarily prolonged therapy.
That's smart, especially for high-risk medications. Speaking of which, controlled substances like opioids have incredibly strict rules, don't they?
They absolutely do. Both federal and state guidelines are very rigid, very strict.
So what does that mean for the nurse day to day?
Well, you're responsible for proper storage, usually locked cabinets, or those secure computerized dispensing systems. You also have to meticulously maintain a running count every time a dose is dispensed.
Every single time.
Every time. And if only a partial dose is given, another nurse has to witness you disposing of the unused portion. Document everything.
Wow.
Yeah, violating these rules carries severe penalties. It really highlights the high stakes involved.
That definitely emphasizes the level of responsibility. Now let's shift gears a bit. Medication names. They can be kind of confusing sometimes, right? There's the chemical name, which we hardly ever use.
Right, too complex.
Then the generic and the trade name.
Exactly. The generic name is the official, non-proprietary name. It's approved by the U.S. and Council. They're like the official namers of drugs. Acetaminophen is a perfect example.
Okay, acetaminophen.
Then there's the trade or brand name. That's what the manufacturer markets it as, like Tylenol,
Right.
One drug, multiple names sometimes.
But similarities in those trade names can easily lead to errors. I've heard about tall man lettering to help with that.
Yes, exactly. The Institute for Safe Medication Practices, ISMP, strongly recommends tall man lettering. It uses mixed case letters like amiloride versus amlopine.
Ah, I see it. Makes the difference stand out.
Precisely. It's a visual cue to prevent confusion between meds that look or sound alike. It's a common source of errors, so it really helps.
Good tip.
And broadly, medications are also classified by what they do or which body system they affect. Aspirin, for example, is an analgesic, an antipyretic, and an anti-inflammatory.
So it fits in multiple classes.
Right. Relieves pain, reduces fever, fights inflammation.
Okay, here's where it gets really interesting for me. Once a patient actually takes a medication, what happens inside their body? It's not just, swallow and done. There's this whole dynamic process called pharmacokinetics.
That's right, pharmacokinetics. It's essentially the journey of a medication through the body, how it gets in, where it goes, how it's broken down, and then how it leaves.
ADME, right, absorption, distribution.
Metabolism and excretion.
ADME.
Exactly. And understanding this is vital for a nurse. It directly influences when you give a drug, what route you choose, and how you anticipate and evaluate the patient's response.
Okay, let's kick off with absorption. How does a medication get from where you give it into the bloodstream?
So absorption is that initial step, and the route of administration is a huge factor. Think about it. IV medications, they bypass absorption entirely.
Straight into the blood.
Yep. Immediate effect, the fastest. Intramuscular and subcutaneous injections are generally faster than oral meds because oral meds have to navigate the whole GI tract.
Makes sense.
But beyond the route, the drug's form and its pH are critical too. Like, a liquid pain reliever often hits faster than a tablet because it's already dissolved.
Okay.
And remarkably, your stomach's acidity means acidic drugs actually get a head start on absorption right there, while basic ones tend to wait until the small intestine.
Huh, interesting.
Yeah. Also, areas with rich blood supply and large surface areas, like the small intestine, absorb medications much more quickly. More surface, more absorption.
So as a nurse, you're not just handing out a pill, you're thinking about how the body will react to it based on all these factors.
Precisely. For instance, some oral medications absorb way better between meals, so you'd plan administration times around that.
So you need to know that.
Exactly. It requires critical judgment and often looking things up, consulting pharmacology resources. You can't just guess.
Okay, so once it's absorbed, where does it go?
Yeah.
That's distribution, right?
Exactly. Distribution is how medications travel through the bloodstream to tissues and organs and eventually to their site of action.
What affects that?
Well, circulation is obviously key. If a patient has impaired circulation, maybe from heart failure, the medication might not reach its target as efficiently. Delivery slows down.
Okay.
Another crucial factor is protein binding. Many medications bind to proteins in the blood like albumin. But here's the critical point. Only the unbound or free medication is active.
Only the free part does the work.
Right. And a common pitfall for nurses, something you really need to watch for, is that in older adults or patients with liver disease or malnutrition, their albumin levels can be low.
Ah, okay, so what does that mean?
It means there's more unbound active medication floating around, which significantly increases their risk of medication activity, even toxicity, at a normal dose.
Wow, okay. More active drug than you'd expect. So after distribution, how does the body process it?
Next up is metabolism, or sometimes called biotransformation. This is where the body converts the medication into a less active form, usually so it can be excreted more easily.
And the liver's the big player here.
The liver is the primary site for this. It acts as a crucial detoxifier, breaking down potentially harmful chemicals.
So if the liver isn't working well...
Exactly. If liver function is decreased, maybe due to aging or disease, the medication is eliminated much more slowly. It can build up.
Got it.
I mean, imagine a small sedative dose of, say, a barbiturate causing a coma in a patient with liver disease simply because their body can't process it efficiently. It accumulates.
That's a serious risk. Okay, and finally, how does the body get rid of it? Excretion.
That's excretion, the last step. After metabolism, the medications or their metabolites exit the body. The kidneys are the main excretory organs.
So kidney function is crucial too.
Absolutely. If a patient's kidney function declines, medications aren't adequately removed. This leads to increased toxicity risk, which often means the dose has to be reduced.
Okay. Are there other ways out?
Yeah. Other routes include the lungs for gaseous compounds, like anesthesia gases. And the GI tract issues, like very slow peristalsis, can affect how quickly drugs are eliminated that way too, even exocrine glands, like sweat or saliva.
So thinking about this whole ADME process, what does this all mean for you as a nurse in practice?
Well, understanding this entire journey, absorption, distribution, metabolism, excretion, helps you anticipate effects, understand potential risks, and truly personalize care.
Right.
It ensures the patient gets the most benefit from their medication with the least amount of harm. It's fundamental.
Okay, so beyond the desired outcome, the therapeutic effect, what else might happen when a patient takes a pill? And how do nurses prepare for that? Medications can have, what, a whole range of effects, right? Good, bad, unexpected.
That's a really crucial area for a nurse's vigilance. You're always watching. First, you have the therapeutic effect. That's the expected physiological response we want,
Right.
like nitroglycerin reducing cardiac workload. That's the goal. But then we have adverse effects. These are undesired, unintended, and often unpredictable responses. They can range from mild, like a rash, to severe, even life-threatening.
And that's where MedWatch comes in again.
Exactly. Nurses are key in identifying and reporting these, especially serious ones, to the FDA via MedWatch. That helps build a safer medication database for everyone. Keep an eye out, especially in patients who are very young, very old, pregnant on multiple meds, or have liver or kidney disease. They're at higher risk.
Okay, so adverse effects are the serious, unexpected ones. What about side effects? I feel like I hear those terms used interchangeably sometimes.
Yeah, people often mix them up, but they are different. Side effects are generally predictable and often unavoidable adverse effects that occur at usual therapeutic doses, like drowsiness from an antihistamine, or maybe some blood pressure medications causing a dry cough, or common GI issues like nausea with certain antibiotics.
Okay, predictable, maybe annoying, but not usually dangerous.
Usually, yes, though they can be significant enough that they're actually a frequent reason patients stop taking their medications, which really underscores the importance of patient education.
Ah, good point.
Letting them know what to expect, that it's usually manageable, maybe strategies to cope, that's key.
And then there are toxic effects, which definitely sound much more severe.
They are. Toxic effects happen from prolonged intake of a medication or when it accumulates in the blood,
Yeah.
often due to impaired metabolism or excretion, and yes, they can be lethal.
Like an overdose situation.
Essentially, yeah. Think of severe respiratory depression from too much morphine. That's a toxic effect. Fortunately, for some toxic effects, specific antidotes exist, like naloxone, Narcan, to reverse opioid toxicity.
Okay. What about those completely unpredictable, totally out of the blue reactions? The ones you just can't see coming?
Those are called idiosyncratic reactions. This is when a patient reacts completely differently from what's normally expected.
Can you give an example?
Sure, like a child becoming agitated and hyper from an antihistamine like Benadryl instead of getting drowsy. It's the opposite effect. These reactions are currently impossible to predict.
Wow. And the most serious, of course, are allergic reactions.
Yes, allergic reactions are unpredictable immunological responses. The body's immune system reacts to the drug as if it were a foreign invader.
And anaphylaxis is the worst kind.
Right. The most severe anaphylactic reactions are absolute life-threatening emergencies. They involve sudden constriction of airways, swelling in the throat, wheezing, shortness of breath.
Needs immediate action.
Immediate medical attention is vital. This is why continuously checking for known allergies and making sure patients wear those allergy identification bracelets are such crucial nursing responsibilities. Non-negotiable.
Absolutely. Now, beyond the direct effects, there's also how the body adapts to a medication over time or even starts to rely on it. That brings us to tolerance and dependence, all right?
Exactly. Two important concepts. Medication tolerance means a patient needs higher doses over time to achieve the same therapeutic effect. Their body adapts.
Okay.
And medication dependence or addiction can be either physical or psychological. Physical dependence is a physiological adaptation. The body gets used to the drug being there. If it stops suddenly, you get withdrawal symptoms.
That's right.
Nurses play a crucial role here, especially in caring for patients with addiction, ensuring they receive compassionate, non-judgmental, evidence-based care.
And you mentioned timing earlier.
Yes. Beyond what a medication does, when you give it is incredibly important. Medications are timed based on their pharmacokinetics, how quickly their effect begins, onset, how intense it gets, peak, and when it wears off, duration.
And keeping it simple for patients.
Absolutely. When teaching patients, use clear, familiar language like take this in the morning and evening rather than, bead or other medical jargon. Keep it simple and clear.
Okay, so we understand the why and the what happens. Now, how do we physically get these medications into the patient? There's a whole array of methods, right? Routes of administration, each with its own nuances and important safety considerations.
Indeed. And the chosen route always depends on the medication itself, the desired effect, like how fast we need it to work, and, of course, the patient's condition. Can they swallow? Are they MPO?
That makes sense. Let's start with the most common.
Oral. Oral administration, taking meds by mouth, is generally the easiest and most common route. But it's contraindicated if a patient can't swallow, if they're nauseous or vomiting, or have certain GI issues like suctioning.
And safety. Shaking risk.
Huge safety point.
Yeah.
Preventing aspiration. Always position the patient upright, sitting up, usually 90 degrees if possible. Suggesting a chin-down position can help too, and administer one pill at a time, especially if swallowing is difficult.
Good tips. What about crushing pills?
Always check first. Use the ISMP's Do Not Crush list. Many medications, especially extended release or enteric-coated ones, absolutely cannot be crushed safely. It can cause dose dumping or other problems.
Okay. And what about giving meds through enteral tubes, like a feeding tube, NG tube, G tube?
For enteral tubes, the absolute #1 priority is to verify tube placement before administering anything. every single time.
Critical step.
Absolutely critical. You also administer each medication separately. Don't mix them together. Flush the tube with water, usually 15-30 milliville, before the first med, between each med, and after the last med.
Why flush
To
between?
prevent them from interacting in the tube and to make sure the whole dose gets through. Also, be mindful of incompatible medications that might require holding tube feedings for a certain time before or after.
Got it. And there are new connectors now.
Yes, keep an eye out for the new ENFit connectors. They're designed specifically for enteral systems to prevent dangerous misconnections, like accidentally connecting IV tubing to a feeding tube, a major safety improvement.
Good to know. Okay, next up. Topical medications, creams, patches, things applied to the skin or mucous membranes.
Right. Topical medications primarily have local effects, right, where you apply them, but systemic absorption can occur, especially if the skin is thin, broken, or if it's applied over a large area.
So wear gloves.
Always wear gloves when applying topicals. Protect yourself and prevent absorption through your own skin.
What about transdermal patches, like nicotine or fentanyl patches?
Patches deliver meds over a longer period. With these, it is critically important to remove the old patch before applying a new one,
Why is that so critical?
because leaving old patches on can lead to overdose. Imagine having 2 or 3 fentanyl patches on that can be life-threatening. Always remove the old one, cleanse the skin, and document the new patch placement carefully, rotating sites.
Wow, okay. Definitely remove the old patch. What about eye drops or ear drops?
For eye installation, gently pull down the lower lid to form a pouch. Instill the drop into the conjunctival sac, not directly onto the sensitive cornea. And super important, don't let the dropper touch the eye itself to prevent contamination.
Okay.
For eardrops, make sure they are at room temperature first. Cold drops can cause dizziness or vertigo. Straighten the ear canal appropriately based on age, and use sterile solutions if the eardrum might be ruptured.
Got it. And then there's inhalation.
Inhaled medications are rapidly absorbed by the rich network of blood vessels in the respiratory tract. Think inhalers for asthma.
How do you ensure patients use them right? Technique seems key.
Technique is everything. When teaching patients to use inhalers like pressurized MDIs, emphasize proper technique. Shaking the inhaler if needed, proper positioning, slow, deep inhalation, and holding their breath for about 10 seconds to allow the medication to deposit deep in the lungs.
What about spacers?
Spacer devices can significantly improve medication delivery, especially for patients who have trouble coordinating the puff and the breath. Highly recommended for many.
And for steroid inhalers?
Ah, yes. Always instruct patients to rinse their mouth thoroughly with water after using inhaled corticosteroids. This helps prevent nasty fungal infections like oral thrush, rinse and spit.
Good practical advice. Now for the most invasive route, but often necessary, parenteral injections, needles.
Yes, injections deposit medication directly into body tissues. They're used when oral isn't an option or when we need rapid effects.
What are the main principles?
The overarching principles for all injections are meticulous aseptic technique, keep everything sterile. Minimizing discomfort is also key. Use the sharpest possible needle, the smallest gauge appropriate for the site and medication. Inject smoothly, maybe use a vapor-coolant spray first. And selecting the correct site and needle size based on the patient's build, weight, and the medication's viscosity is crucial.
Okay. And how do you prepare medications from, say, ampoules or vials?
Right. If you're drawing medication from a glass ampule, you must use a filter needle to draw the medication.
Why a filter needle?
To prevent tiny glass particles from being drawn into the syringe along with the medication. You then change to a regular needle for injection.
Okay.
And vials. When using a vial, you typically inject an equivalent volume of air into the vial before withdrawing the medication. This prevents a vacuum from forming and makes it easier to withdraw the liquid accurately.
Good tip. What about insulin? That seems high risk.
Insulin is absolutely a high-alert medication because errors can have severe consequences. It's standard practice, often required by policy, to have another nurse independently verify the dose before you administer it. 2 sets of eyes.
Always double-check insulin.
Always. Also, remember to gently roll cloudy insulin preparations, like NPH, between your palms to resuspend them. Never shake it. That creates bubbles which interfere with accurate dosing.
Got it. Okay, let's touch on the actual injection techniques, starting with subcutaneous or sub-Q.
Right. Subcutaneous injections go into the loose connective tissue, the fatty tissue, just under the dermis. We use small volumes, typically less than 1.5 milliliters for adults.
Where do you usually give them?
Common sites include the outer posterior aspect of the upper arms, the abdomen below the costal margins to the iliac crests, at least 2 inches from the umbilicus, and the anterior aspects of the thighs. The upper back and upper ventral or dorsal gluteal areas can also be used.
And rotation.
Yes, it's crucial to use intrasite rotation within the same body area. If you keep injecting in the exact same spot, it can cause tissue damage and affect absorption. Rotate systematically.
Okay. Any specific safety notes for sub-Q?
Yes, a key safety note for nurses. Current evidence shows you generally do not need to aspirate, pull back the plunger for subcutaneous injections like insulin or heparin. And for low molecular weight heparin like Lovenox, it often comes in a pre-filled syringe with an air bubble. Remember not to expel that air bubble before injecting. It helps seal the medication in.
Ah, okay, don't flick out the bubble. Good to know. Next, intramuscular injections, IM.
IM injections go deeper into muscle tissue. Muscle has a richer blood supply than sub-Q tissue, so absorption is generally faster. You use a 90-degree angle for insertion.
Which sites are best?
The ventrogluteal site, the hip area, is generally considered the safest and preferred site for adults and children. It's deep, away from major nerves and blood vessels. You locate it using specific bony landmarks.
Okay, ventrogluteal preferred. What else?
Vastus lateralis, the outer thigh muscle, is often used for infants and toddlers, especially for immunizations. And the deltoid muscle in the upper arm is okay for smaller volumes, like vaccines in adults, typically 1 LML or less. But it's close to nerves, so site selection is critical.
You mentioned the Z-track method earlier.
Yes, the Z-track method is highly recommended for all IM injections, especially irritating ones. You use your non-dominant hand to pull the skin laterally or downward before injecting. Hold the skin taut, inject, wait 10 seconds, withdraw the needle, and then release the skin.
How does that help?
It creates a zigzag path through the tissues that seals the medication into the muscle. This prevents leakage of the medication back up the needle track into the subcutaneous tissue, which minimizes irritation and discomfort.
Clever. And aspiration for IM.
Current guidelines suggest aspiration is generally not needed for vaccine administration via IM route. For other IM meds, follow agency policy, but the trend is moving away from routine aspiration for most IMs.
Okay. And the fastest route of all, intravenous,
5 administration delivers medication directly into a vein, provides the most rapid onset of action because it goes straight into the circulation.
Who prepares 4Vs?
Pharmacies usually prepare large volume 4V infusions, especially those with additives like potassium. Nurses typically don't mix high-alert meds into IV bags unless it's an emergency situation, and protocols allow.
What about 4 push meds?
For 4V bolus, or push medications, it is absolutely critical to verify the recommended rate of administration. Pushing a med too fast can cause severe adverse reactions, even death with some drugs. Look it up every time. Don't guess.
So know your push rate.
Know your push rate and follow it precisely. Patients receiving IG push meds, especially potent ones, often need continuous monitoring, maybe in specific care areas like ICU.
Right. And finally, safety for the nurse needle sticks.
Yes. Needle stick prevention is paramount for your own safety. Occupational exposure is a real risk. Regulations mandate the use of safety needle devices, needles that retract, shield, or blunt after use. And always dispose of all used needles and other sharps immediately into designated puncture-proof containers. Never recap a used needle.
Essential safety practice. Okay, so we have the routes, but for all of these, the math has to be absolutely perfect, right? A small decimal error can have huge consequences.
Absolutely. That's why understanding medication measurement and clinical calculations is non-negotiable. The metric system is the preferred system in healthcare for its precision and ease of use. Moving between units involves multiplying or dividing by 10, 100, 1,000.
Any key safety rules with metric?
Yes, 2 critical safety rules regarding decimals.
Yeah.
Always use a leading zero before a decimal point for doses less than 1. Write 0.25 milligrams, not 0.25 milligrams. That naked decimal point can be easily missed.
Oh, wait, leading zero.
And never use a trailing zero after a decimal point for whole numbers. Write 5 milligrams, not 5.0 milligrams. That trailing zero can be misread as 50 milligrams if the decimal isn't seen clearly. These simple rules prevent potentially devastating tenfold errors.
Got it. Leading zero, no trailing zero. What about household measures? Teaspoons, tablespoons?
Avoid them whenever possible. They are notoriously inaccurate. A teaspoon from your kitchen drawer can vary wildly. The ISMP actually recommends that pharmacists dispense oral liquids in metric-only oral syringes for parents and patients to use at home. Much more accurate.
Good point. And for calculations themselves?
There are different methods: ratio and proportion, formula method, dimensional analysis. Find one that works for you and master it. But more important than the method is the critical thinking. Always estimate the answer first. Does the calculated dose seem reasonable? If you're giving half a tiny tablet, should the dose be 20 millirho? Probably not.
Makes sense. Ballpark it first.
Yes. And then double-check all calculations, especially for high-risk medications like heparin, insulin, or chemotherapy drugs. Often, policy requires a second nurse to independently verify your calculation for these meds. Don't skip that step.
Okay. Pediatric doses present an even higher risk, don't they? Calculations must be spot on.
They absolutely do. Children are at a much, much higher risk for medication errors, and the consequences can be far more serious because of their small size and immature organ systems.
So what are the key principles for PEDS dosing?
Doses are almost always based on weight, milligram per kg, or sometimes body surface area. They're much smaller than adult doses and require incredible precision in measurement. Use small syringes, like a tuberculin syringe, for very small volumes, especially less than 1 mmL, to measure accurately. Rounding rules are also critical. Follow them carefully. And again, estimate, calculate carefully, and double-check, often with another RN. These small differences can be life-altering for a child. Meticulous calculation and verification are essential.
Okay, so beyond the science, the routes, the math, the core of safe medication administration really lies in your vigilance and critical thinking as a nurse. It ultimately comes down to you at the bedside.
Absolutely. It starts even before you have the med in hand, with how medication orders are received. Computerized provider order entry, CPOE, has reduced errors significantly, which is great.
But verbal orders still happen.
They do, especially in emergencies or telephone orders sometimes. If you take one, you must be an authorized staff member, usually an RN. And the crucial safety step is to read back the complete order to the prescriber for confirmation. Document it immediately, including the readback confirmation, and ensure the provider signs it off, usually within 24 hours per policy.
And a note for students?
A critical note, nursing students cannot take telephone or verbal orders. That's a license responsibility.
Good clarification. And abbreviations. They can be a real minefield, can't they?
Oh, they are a major source of medication errors. ISMP and the Joint Commission have lists of prohibited and error-prone abbreviations that you absolutely must avoid.
Like what?
Things like using U for unit, easily mistaken for 0 or 4, IU for international unit, mistaken for IV or 10, QD or QOD for daily or every other day. Write it out. Using those trailing zeros we talked about, or naked decimal points, using G instead of writing mcg or micrograms, these seemingly small details can lead to huge mistakes. Always write things out clearly if there's any doubt.
Got it. Avoid dangerous shortcuts.
But even with all these systems, errors can still happen. What's the nurse's ultimate responsibility in preventing them?
Well, the National Coordinating Council for Medication Error Reporting and Prevention defines a medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in the control of the healthcare professional, patient, or consumer. Your vigilance is the final safety check.
And this is where the rights come in.
Exactly. This is where the foundational 7 rights of medication administration are absolutely essential. You check them every single time. The right medication, right dose, right patient, right route, right time, right documentation.
And the 7th, and the often added, very important, right indication. Why is the patient getting this medication? Does it make sense for them?
Okay, those are the core rights. What are some other key best practices to really embed safety?
Beyond the rights, which are critical, always use at least 2 patient identifiers every time you administer medications. Name and date of birth are common. Check the armband, ask the patient. Don't just rely on the room number.
2 identifiers every time. What else?
Avoid any interruptions during medication preparation and administration. This is a high-risk time. Some units even have designated no interruption zones or wear special vests during med passes. Minimize distractions.
Makes sense.
You absolutely must double-check all high-risk calculations, often with another nurse. Question any dose that seems unusual, too large, or too small. If handwriting is illegible, clarify it before giving the med. Don't guess.
And documentation.
Document immediately after administration, never before. Documenting beforehand is a major error risk if the patient refuses the med or something changes. Also, ensure you are well rested. Fatigue contributes to errors, and always use technology like barcode scanning systems as they are intended. Never implement workarounds. They defeat the safety purpose.
Okay. What about reconciling meds?
Medication reconciliation, comparing the patient's current med list to newly ordered or changed meds, is vital at transition points like admission, transfer, or discharge to prevent errors. And finally, comprehensive patient education is a huge prevention strategy. An informed patient is a safer patient.
It really sounds like the entire nursing process provides a framework for medication safety.
It absolutely does. It guides your thinking.
Mm-hmm.
In the assessment phase, you're looking at the whole picture, importantly through the patient's eyes.
Mm-hmm.
What are their preferences? Cultural or religious beliefs that might affect medication use? Can they afford the medications?
And their understanding.
Yes. Critically, what's their health literacy and numeracy? Do they understand the instructions? You might use the teach-back method here. Ask them to explain it back to you to confirm their understanding right from the start.
What else in assessment?
You review their medical history, allergies, diet history for contraindications or interactions.
Right.
You assess their current physical and mental condition. Do they have any perceptual or coordination problems like arthritis that might make it hard for them to self-administer, say, drawing up insulin?
Real-world application.
Exactly. This assessment data then informs your analysis and nursing diagnoses. Maybe it's complex medication regimen or risk for non-adherence. This guides your individualized interventions. Is the issue financial? Or does the patient need a better teaching plan?
And then comes that patient teaching piece again in planning.
Yes, planning involves setting goals and outcomes, like patient will verbalize understanding of medication schedule by discharge. And comprehensive patient and family teaching is a major intervention. Cover the purpose, actions, timing, dosages, side effects, what to report, the importance of finishing antibiotics, make it clear, use teach-back.
Then implementation and evaluation.
Right. Implementation is where you actually prepare and administer the medication, applying all those safe procedures we discussed for each route.
Mm-hmm.
And crucially, evaluation happens post-administration. You assess for the intended therapeutic effects, but also for any side effects or allergic reactions.
How do you evaluate?
Use both objective measures, checking blood pressure after an antihypertensive, looking at lab values like INR for warfarin, and subjective patient statements, does your pain feel better? And you need to return within an appropriate time frame to evaluate.
Like how soon?
Depends on the route and drug onset. Maybe 15 to 30 minutes for quick-acting sublingual or IV meds, maybe 30 to 60 minutes for standard oral medications, or longer for some others. Know when to expect the effects so you can check effectively.
And finally, recording.
Finally, recording and reporting. Document immediately and accurately on the MAR or EHR after administration. Include the drug name, dose, route, time, and your initial signature. Document if a drug was withheld and why, and report any adverse effects according to policy. Accurate documentation prevents errors and ensures continuity of care. It's your legal record.
That nursing process framework really ties it all together. Are there any special considerations for specific patient populations we should highlight?
Definitely. Two big ones are older adults and children. Older adults have a significantly higher incidence of adverse drug events and medication errors.
Why is that?
Partly due to physiological changes of aging. Things like decreased liver mass and blood flow affecting metabolism, declining renal function, slowing excretion, sometimes less albumin for protein binding. All these can increase the risk of drug accumulation and toxicity even at normal doses.
What else with older adults?
They also commonly experience polypharmacy, the use of multiple medications, often prescribed by different doctors, sometimes potentially inappropriate ones. This increases the risk of interactions and adverse effects.
So what can nurses do?
Tips for administering to older adults include trying to simplify the medication regimen if possible, providing very clear, maybe large print instructions, using memory aids like pill boxes, and always assessing their functional status. Can they physically open the bottle or manage an inhaler?
Okay. And children?
As we mentioned with calculations, children have that much higher risk for medication errors due to their smaller, weight-dependent doses, rapid growth, and immature systems. Doses require incredibly precise measurement. Hands-on demonstration is often needed for teaching families how to give liquid meds accurately using an oral syringe, for example. Extra care and double checks are vital.
Wow, okay. That was a truly comprehensive deep dive into medication administration. It is so much more than just, giving a pill. It's really a holistic, patient-centered, and science-driven practice that demands incredible vigilance and critical thinking from nurses.
Indeed it does. And as you move forward in your nursing journey, whether you're a student or practicing, remember to always embrace that critical thinking. Commit to continuous learning because things change, and maintain that unwavering vigilance. Your role as a nurse is absolutely essential in ensuring patient safety and achieving the best possible outcomes in what is, let's face it, a really complex healthcare landscape.
That's a great point. And here's a final thought for you, our listeners, to consider. As you move forward in your nursing journey, how might we, as healthcare professionals, potentially leverage emerging technologies, AI, personalized medicine tools, maybe smarter delivery systems to further personalize medication administration, while always ensuring that vital human connection, that nursing judgment and oversight remain absolutely paramount? Something to think about. Last minute lecture team, thank you so much for engaging in this deep dive with us today and for being such a vital part of our learning community. Keep up the great work.